There's been a renewed interest in total laparoscopic approaches for pancreaticoduodenectomy. Also recently, there's also growing enthusiasm for robotics to assist with the laparoscopic procedure. We have a very small experience so far with just 15, but advantages: three-dimensional view. It replicates more closely the open skills, therefore there's not as much need for the advanced laparoscopic skills that you might need without that. It does add some maneuverability. However, I do think there's some disadvantages. There's no haptic feedback, and I think in pancreas surgery that's pretty important. The surgeon is remote from the patient, there's setup time, and then there's the expense and availability of the robot itself. I'm going to talk mostly about total laparoscopic pancreaticoduodenectomy, and the indications, I think, are just the patient, first of all, needs to be a candidate for an open procedure and should lack any prohibitive comorbidities. In other words, we shouldn't expand the indications for pancreaticoduodenectomy just because of the minimally invasive approach, especially in this early experience. Also, the patient needs to consent. This is a new approach. Contraindications, I think, are somewhat relative and some are absolute based on the surgeon experience. Tumor involvement of the portal vein or superior mesenteric vein. And certainly, I think the lack of open pancreatic experience for those who may be advanced laparoscopists, and also the lack of advanced laparoscopic skills for those who may be good pancreatic surgeons. I think both are a must. Therefore, to make it a little bit easier in the initial series, I think one of the things we've learned is to ease resection, perhaps in the beginning of someone's experience, those things that might make the resection a little bit easier would be benign disease, so that you're not worried about oncologic principles and violating those early in your experience. The lack of major abdominal operations in the patient. These can be lengthy operations, the pancreaticoduodenectomy in the early experience, and therefore adding another hour or two of lysis of adhesions, the surgeon will run out of patients far before the procedure's done. Typical vascular anatomy, while it's certainly possible, and we've done several with replaced right hepatic arteries and other vascular anomalies, I think that these are things that just add more time and tediousness to the beginning of the learning experience. Also, lesions that are remote from the portal vein and superior mesenteric vein to make an easier uncinate dissection. Certainly, to ease the reconstruction, however, those patients with a large pancreatic duct, bile duct, and a firm pancreas